I'm not a clinician, so my perspective is obviously different. So my sense is that in terms of specifically trying to distinguish AL amyloidosis from ATTR amyloidosis, and that is perhaps particularly important for cardiac type of amyloidosis, because the most accurate way for diagnostics is through organ biopsy. And it appears that even though various tissue biopsies, such as fat aspirates, provide some information, but the most accurate diagnostics is through biopsy in case of cardiac amyloidosis by endomyocardial biopsy, which of course is risky and difficult and not suited for all patients. So as an alternative, there is a non-invasive modality, which is uptake of radioactive tracers, which are also taken up by the bone, such as technetium-labeled phosphates, pyrophosphates, diphosphonates, so various phosphate salts. And for unknown reasons, those tracers preferentially, but not only and not always, are taken up by ATTR as compared to AL. And both types of amyloidosis are associated with some calcification, and we just discussed calcification in a different disease, but perhaps through somewhat similar mechanisms, why calcium phosphate deposits in the vicinity of amyloids. But then the question arises, do these calcifications fully account for the differences in the uptake of these bone tracers by ATTR versus AL amyloidosis? And also, what is the nature of false positives and false negatives? Why do some, but most, but not all ATTR fibrils pick up bone tracers? And why do some non-ATTR fibrils also pick them up? And of course, the accuracy of diagnostics is absolutely paramount for treatment, which is protein specific. So it appears that amyloid-specific calcification doesn't explain the whole picture. And it seems like the fibril structures, again, provide some insight into these differences in the bone tracer uptake. And here again, it boils down to the acidic residue arrays on the amyloid surface. And as I mentioned previously, it takes two adjacent acidic residues to bind one calcium ion, in addition to some oxygens from elsewhere. But two acidic residues are necessary for high affinity binding. So we think that amyloid fibrils, which have two acidic residues from the same molecule, binding, sitting next to each other on the amyloid surface, exposed to the environment, not blocked by any other portions of amyloid. If they can bind a calcium ion and there is enough room around them, then they can also bind, through calcium, they can also bind diphosphonates or pyrophosphate, and those can pick up the tracer. So essentially, calcium binding to amyloid, high affinity calcium binding to amyloid, mediates tracer binding, bone tracer binding. And this high affinity calcium binding requires two adjacent acidic residues. And then we looked at different available patient-derived structures of amyloids from patients with ATTR versus AL. And it appears that all ATTR patients, maybe with a couple of exceptions, at least all those who have so-called type A fibrils, which are known to uptake the tracer, they have such exposed acidic residue pairs, which helps explain why they would be expected to bind the bone tracer. Whereas most, but not all, of AL fibrils don't have such residue pairs, and that helps explain why bone tracers and calcification is more intense for ATTR as compared to AL. But again, there are many unknowns remaining. There is no direct experimental proof for this mechanism, even though it makes perfect sense and it agrees with all available experimental data. But there is no picture, for instance, no high-resolution structure of a bone tracer bound as we expected to bind to amyloid. And we also don't have type B fibril structure of ATTR, which hasn't been solved yet. So we hypothesize that perhaps these similar sites are truncated or maybe not available or blocked from binding bone tracers in type B fibrils, because those are comprised of full-length TTR molecules, so perhaps the linker connecting the two pieces of this molecule blocks the binding site. But again, this has to be proven experimentally, and so far we don't have the structures. So whoever is working on type B ATTR structure, please, we would be delighted to see what the structure looks like. And in addition, there are generally very few fibril structures that have additional molecules bound to it that have been identified, being calcium or bone tracers or apolipoproteins. And part of the reason is to determine a fibril structure by cryo-EM, scientists usually subject the fibrils to pretty harsh purification procedures to make it pure, clean, homogeneous samples suitable for structural studies. But by the same token, many of these bound ligands, which are not bound very, very strongly, are washed off. So we don't see them in the structures. So it would be really nice to try and use less harsh procedures, which some scientists are trying to do, to retain these bound ligands, and also to try and identify many non-proteinaceous extra densities seen in some structures and figure out what they are. So there are lots of remaining unknowns. And all of them, of course, contribute to some extent to difficulties in amyloidosis diagnostics and identification of the fibrillar protein.